The final talk in this morning's session will be actually three presenters, Geoff McKee from UBC, and then Heinz Snyman from the Ministry of Agriculture, and then a surprise speaker, Richard Rusk, all the way from Manitoba Public Health. And so, not sure if we're talking about 2 or 3 cases. Is it maybe 3? 2 cases of blastomycosis.
Okay.
Ready to go, Geoff?
Yeah, is this?
Yeah.
Oh, fantastic. Okay. How's the sound on that? Is it? Oh, okay. There we go. Okay. Perfect. Okay. Good morning. Thank you for the introduction and for the opportunity to present here today. This morning we'll be presenting an overview of blastomycosis as well as 2 recent cases of animal infections in British Columbia. We hope to use these cases to build a context for discussion on the potential hazards of imported blastomycosis in the province, particularly on whether it presents a risk of environmental contamination and human infection. So I'll start off quickly by reviewing blastomycosis, and then I'll discuss a case of canine blastomycosis that I was involved with when I was working as a resident at the BC CDC. And then Dr. Snyman will follow this with a case with the red panda in British Columbia, and we'll have a couple slides from Dr. Rusk as well. So, just some comic relief there. I was kind of curious I found this. Interesting name for a heavy metal band. Okay, so before we begin, I'd just like to acknowledge some of the folks who were involved when I was working with the canine case here and helped out on some of the presentation as well, which was wonderful. And just some of the objectives, so as I said, we'll review blastomycosis, just a brief overview. I'll talk about my canine case, then we'll go on the red panda case and finish up with some discussion in Dr. Rusk's slides. So, okay. So although I'm sure many here are familiar with blastomycosis, I thought a quick review would be useful given its relative absence here in the West. Blastomycosis is a systemic pyogranulomatous infection endemic to regions of Midwestern and Eastern North America. The etiologic agent, Blastomyces dermatitidis, was first discovered in 1894 here by Dr. Kaspar Gilchrist. He was a dermatologist in Baltimore. So some of you actually may have heard of this disease. It also goes by the name Gilchrist disease, also sometimes known as Chicago's disease as well. Although it was initially thought to be caused by a protozoan, it was later identified as a dimorphic fungus, which means that it exists in both mycelial and yeast forms. So genetically, it actually shares similarities with some other fungi, including Paracoccidioides, Emmontia, and Histoplasma species. And recently, a related species under the same genus of Blastomyces was also discovered, Blastomyces gilchristii, which may also be a potential etiologic agent of this infection. So with regards to the epidemiology, many may be familiar with blastomycosis as predominantly a disease of Eastern North America, as indicated here by the brown shading. In the United States, blastomycosis is hyperendemic to areas of the East and Midwest, particularly those states bordering the Mississippi and Ohio rivers, as well as the Great Lakes. Sporadic cases have been identified in other areas of the South and Midwest, although that's typically associated with travel history to endemic regions. There have also been various reports in isolated cases in the West, including Colorado. Now, with regards to Canada, the fungus is endemic to the southern regions of central and eastern provinces. It's hyperendemic to southern Quebec, Ontario, Manitoba, predominantly in the east, with recent evidence in cats and dogs in Saskatchewan. There is no evidence of cases arising natively here in British Columbia, although it hasn't necessarily been a reportable disease in the past. However, I found at least one human case in the literature that was associated with travel history. And as noted here, there are case reports of cases of blastomycosis outside of North America, including in places in Africa and also the Middle East. So it does suggest a global distribution of this fungus. Now, this is one of the most interesting parts. The environmental factors are significant with regards to the distribution of blastomyces. As I mentioned, there are two forms of blastomyces, and it typically exists in the mycelial form in the environment, as opposed to the yeast form, which is involved in infection. The Blastomyces canidia, or the asexual spores, bind tightly to the microphilia of the mycelial form, and actually require high levels of humidity to become dislodged and available for distribution. Transmission is thus reported to be associated with exposure to moist environments, including areas along streams and rivers. It's particularly prominent when there's disruption of the moist soil, which leads to aerosolization of the infectious canidia. Now, although there appears to be ecological characteristics involved with the transmission, there is conflicting evidence on whether there's seasonal association or other associations with weather patterns, etc. So, there we go. So Blastomyces has a wide range of animal hosts. Humans and other animals, including dogs and cats, are competent hosts for Blastomyces, predominantly dogs over cats. And as noted here, there's a number of other potential hosts, including lions, foxes, and as we'll come to in a bit, red pandas. So the most common mode of transmission is through inhalation of the airborne canidia, and thus most cases present with the pulmonary manifestations. Other modes of transmission have been identified, including cutaneous inoculation through things like infected dog bites. However, this is quite rare. We will see a cutaneous manifestation in one of the upcoming cases, although it's a bit up in the air on whether it started as a pulmonary infection and led to some extrapulmonary symptoms. Of particular interest, there is reportedly no evidence of airborne transmission going from animals, infected animals, to humans. Intriguingly, there have been other reports in the literature of other modes of transmission, including at least one reported case of intrauterine transmission through prostatic fluid, which is it was back in the 80s, so there hasn't been too many since. Okay, just a bit on clinical disease. So the clinical disease and management strategies are actually quite similar between humans and other animals. In humans, the incubation period for blastomycosis is estimated to be between 21 and 106 days, with an average of about 45 days. It appears to vary a bit among the literature, from 2 to 3 weeks to potentially longer. In other hosts, such as dogs, it also varies among the literature, with some reports of more prolonged latent phases. Given the airborne mode of transmission, the majority of cases present with pulmonary manifestations. However, a significant portion of cases may present with extrapulmonary symptoms. Some patients may also remain symptomatic, which leads to potential reactivation later in life. Diagnosis typically confirmed through histology and culture of specimens, obtained from abscesses, sputum, lymph node aspirate, etc. Identification of anti-blastomyces antibodies and polymerase chain reaction are other modes of diagnosis. And just briefly on treatment, the modes of treatment typically depends on the severity of disease. So azoles are often used for mild manifestations. Predominantly in humans, it's itraconazole, although there's also cases fluconazole has been used in dogs. And then for those more severe manifestations, typically the go-to agent is amphotericin B. And luckily, according to the literature, there's been Blastomyces dermatitis has retained good susceptibility to these drugs. So, okay, so now after that review, we'll move on to the first case, which is the case I was involved with, which is in a 1.5-year-old Portuguese water dog. And I'd just like to mention that Dr. Michelle Cates, the veterinarian involved in this case, is the owner, and so she gave me permission to use these pictures here. So I'd also like to preface this case by noting that I was involved in the public health response at the BC CDC as a resident, so I wasn't involved in the primary veterinary care, so most of those details were provided by Dr. Cates, because she was the primary vet involved. So this dog presented to the vet, or to Dr. Cates, in January 2015, initially with these skin lesions, which unfortunately the light's not too visible there, but skin lesions on his back. These had developed over the previous week or so, and biopsies were taken, and he was diagnosed with sterile nodular paniculitis. Bacterial cultures came back negative, And so he was started on steroid therapy. Now, shortly following steroid therapy, he took a turn for the worse. He developed a worsening lesion on his foot, which I had hoped to put up here, but I didn't get a chance. And enlarged lymph nodes, fever, and he went into respiratory distress. An enlarged node was aspirated and sent for testing, which confirmed blastomyces on both microscopy as well as PCR. So here's a comparison of pulmonary findings on chest X-ray before and after steroid therapy. I've been told that there's worsening pulmonary infiltrates here, although I'm not used to reading canine X-rays, so I'll leave that to the clinicians, the vets. Given the diagnosis of blastomycosis, he was started on a course of fluconazole. The initial dose did not appear adequate. However, after the dose was increased, he significantly improved. I checked with the vet within the last couple weeks, and he continues doing well on fluconazole. I would believe the treatment will be stopped once a urine antigen test comes back negative for blastomyces. She asked me to use this photo in the conclusion just to show that he came in looking a little worse for wear, but now he's back to his cute self. So this is from actually Halloween. He was dressed up as a sheriff. Okay. So I apologize for this cursory review of the clinical course, but I just wanted to spend a little bit more time on the public health response involved. Following the diagnosis of blastomycosis, the veterinarian notified the BC CDC out of concern that blastomycosis isn't endemic to British Columbia. Another lymph node aspirate was requested, and blastomyces dermatitidis was confirmed on both microscopy as well as subsequent culture. We'll get a little bit more into the histology later on, but there's some very key characteristic findings on microscopy, such as the broad-based budding that we'll see. And we're lucky to culture it. It's not the easiest fungus to culture, so that definitely helped. Given the validation of this diagnosis, we conducted further investigation into the exposure history of the dog. He lived with his owner in a condo in Vancouver and had spent time in dog parks across the city. He'd also traveled considerably within the first year of life, with trips throughout BC, to Washington State, and perhaps most importantly to Manitoba. This trip in particular had occurred approximately 6 months previous, prior to the onset of symptoms, and while in Manitoba he swam in a river at a park. So important going back to where we find this fungus most prominently in the environment. He also spent some time outside the car during the car trip, including stops within Saskatchewan. I should note also at this time we contacted the relevant health authority involved and went through those steps. So following this review of exposures, we were left to consider the risk of exposure here in British Columbia compared to other areas. In doing so, we consulted with our colleagues in BC, in Washington, and other Western states, as well as Saskatchewan and Manitoba. Exposure was deemed unlikely in British Columbia and Washington State, as there has been no evidence of local acquisition in humans other than animals on a literature review and expert consultation. Blastomycosis, as we mentioned, is known to be endemic in Manitoba, although this is primarily notable in the eastern regions of the province along the border with Ontario. There is also, as I mentioned, the evidence literature of blastomycosis in Saskatchewan. So given the likelihood of exposure during the trip to Manitoba, compared to that within BC and Washington, it was concluded that the infection was likely acquired during the trip out east. Nonetheless, we were unable to really prove or disprove local acquisitions, so we decided to take a bit of a wait-and-see approach with further investigation of subsequent cases with uncertain exposure histories. So that concludes my presentation. I just again like to thank Dr. Cates for her help and for providing the photos. And here's some of my references. A few of them. Anyways, so maybe we'll move on with Dr. Steinman's presentation. We can leave questions to the end and we can have a bit of a discussion.